I'm Jesus Berdeja, Director of Multiple Myeloma Research at the Greco-Hainsworth Centers for Research at Tennessee Oncology, and it's my distinct pleasure to be here with you again and what this is called a year in review in multiple myeloma, and I've been asked to talk about T-cell redirecting therapies in particular. So without further ado, we'll proceed. And so we'll start with CAR T-cell therapy, which you all know very well. But one of the main things that happened in the last year and a half is the results of the KarMMa-3 trial. And the KarMMa-3 trial is a phase 3 trial of ide-cel, which is a BCMA-directed CAR T-cell, versus standard of care in relapsed refractory myeloma. So this trial actually looked at patients 2 to 4 prior lines of therapy. They have had a PI, an IMiD, and an anti-CD38 antibodies. So even though it's 2 to 4 priors, it's still a pretty heavily pretreated population. And patients were randomized 2 to 1 to receive lymphodepleting chemotherapy followed by ide-cel and stop, versus investigators' choice of standard of care. And the standard of care therapies were daratumumab, pomalidomide, dexamethasone, daratumumab, bortezomib, dexamethasone, carfilzomib, dexamethasone as the main ones that people used. And so the main primary endpoint was progression-free survival. And as you can see here, the ide-cel outperformed the standard of care both in overall response rates and in progression-free survival, which was the primary endpoint, with a PFS of 13.8 months compared to 4.4 months and a hazard ratio of 0.49. So just to remind you that 4.4 months is actually what we expect to see in patients who've had a PI, an IMiD, and anti-CD38 antibodies. So it goes to show you that this was a pretty heavily pretreated population. They also did a quality of life assessment, and this was published separately. And so basically, what this basically showed was the results from the functional domains, the EORTC, QLQ-C30, and the EORTC, QLQ, MY20, and the EQ5D5L. Basically, all these means that if there's a positive change towards the CAR T, that means there's an improvement in function. And so if you look on the right, that's the top graph there. And so you see that all these parameters are going to the right, meaning that patients actually felt improvement after receiving CAR T versus standard of care. And then at the bottom, you see the results of the symptom domains, which are the EORTC, QLQ, C30, EORTC, QLQ, MY20. And here, a negative change means an improvement in symptoms. And as you can see, most of these symptoms favored the CAR T side. So again, just sort of showing that patients do feel well after they've received a CAR T and an off therapy. So from my standpoint, this tells us that this study actually got a new FDA indication for ide-cel. So prior to that, the KarMMa study got ide-cel approved in adults with 4 or more prior lines of therapy. And after the KarMMa-3 study, now ide-cel is approved in relapsed refractory myeloma after 2 or more lines of therapy. But you have to have had an IMiD, a PI, and an anti-CD38 antibody. And there really were no new safety signals seen in this earlier line population. So similarly, CARTITUDE-4 is a phase 3 trial with cilta-cel now versus standard of care. And this was also a phase 3 trial randomized 1-to-1. Patients were 1 to 3 prior lines of therapy. It only required a prior PI and IMiD and did not specify anti-CD38, but you had to be lenalidomide refractory, which is important for the indication. And so again, patients are randomized to receive bridging therapy, and usually that was basically the same. You had to choose your standard of care therapy before you were randomized. And so if you got randomized to the CAR T, you received 1 to 2 cycles of the same therapy you would have chosen as bridging, followed by the infusion of the CAR T cell, versus standard of care, which was mostly either pomalidomide, bortezomib, dexamethasone, or daratumumab, pomalidomide, dexamethasone. And again, the primary endpoint again was PFS. And so as you can see here on the left, you had the progression-free survival. Primary endpoint was met with cilta-cel on top here in standard of care group, significantly favoring the cilta-cel group. The median has not been reached for cilta-cel. The median for the standard of care, 11.8 months, hazard ratio of 0.26. So again, showing that this is a different population for the KarMMa-3 study. Right there, the standard care arm only PFS was 4 months, and here it's almost a year, which is what we would expect in a patient with prior PI IMiD, but not necessarily anti-CD38 antibody. And only like less than 10% of patients actually had a prior anti-CD38 antibody in this study. One of the things I will mention, if you look at the PFS curves, there's this rapid drop of PFS in the cilta-cel group, and then it kind of evens out. And so the dotted line shows when the patients actually received cilta-cel. So most of those patients that dropped out were due to progression of disease, going to show that some of the logistic issues with CAR T and a patient that has rapidly progressive disease may not be the best candidate, as they may not actually make it to receive their CAR T therapy. Yes, sir. You have a question.
Could you just review what constitutes a line of therapy? For example, if a patient gets induction treatment, transplant, maintenance after transplant, maybe they de-escalate the maintenance, is that all still one line of therapy?
Yeah, so a line of therapy, as defined by the IMWG, is basically requires that the easiest way to think about it is any treatment that is given, even if it's meant to sort of induce a deeper remission. So as long as there's no progression within that line, that is all considered one line. So when patients undergo induction, transplant, and maintenance, all of those are done to continue to deepen that remission. So that is all considered one line. On the other hand, if a patient actually has, initial induction, but then, progresses before you go to transplant, you give them a second line of treatment to get him under control, and then you do the transplant maintenance, those would be considered two lines. And then the other caveat is someone who's having significant toxicity, and you have to stop because of toxicity, you restart a different regimen, that would also be considered a new line. So in this case, most patients who are transplant eligible would have had, an induction with probably 3 drugs at this point, transplant, and then like lenalidomide maintenance, and that would be considered one line. And those patients could have gone on to enroll on the study. So my conclusions, cartridge 4 is similar to KarMMa-3. Again, we had cilta-cel was FDA approved after cartridge 1 for patients with 4 more lines of prior therapy. But the new indication after cartridge 4 is that patients who relapse after just 1 line of therapy could go directly to the cilta-cel as long as they've had an IMiD, a PI, and they have to be refractory to lenalidomide. So it's important to remember that was actually one of the inclusions in their study, and the FDA kind of kept that as an indication. So technically, a patient that has 1 line of therapy and gets bortezomib maintenance, for example, and then relapses, they would not be eligible by this indication.
Yeah,
yes,
but
sir.
they would have had lenalidomide in the induction, right?
Yeah, but the definition of refractoriness, again, by the IMWG, and I'm a member of the IMWG, so don't shoot the messenger, but this is sort of kind of what's been established, is refractoriness means you have to be progressing on the drug or within 60 days of stopping the drug. So if you have had induction and then you progress 2 years later on a different maintenance, then you would not be considered refractory to those previous therapies. I know we like to make things complicated. So my take in this is obviously this is great for patients. This is one of the most active CAR Ts, so we're very happy to have this option. The truth is that in the previous indication, it was very difficult to get through 4 lines of therapy that were actually active, that were truly better than this. So we're very happy with this new indication. But I will caution that as we kind of learn more with these CAR Ts, specifically with cilta-cel, there is still that risk of that delayed neurotoxicity, that Parkinsonian type of toxicity that can be irreversible. And also we're seeing a significant increase in secondary malignancies, definitely in after cartridge 1. Cartridge 4 doesn't seem to have the same incidence, although again it's early, and also these patients are less heavily pretreated, so perhaps that won't stand. But there's definitely a signal for secondary heme malignancies. So in my mind, I really you really need to kind of discuss that with the patient so that you can make a good decision for them. I personally feel that if a patient has not had a prior anti-CD38 antibody, knowing that we can get a PFS of over 3 years with something like daratumumab, carfilzomib, dex, I may choose to go with that route before I go to the CAR T versus the patient that's already had an anti-CD38 antibody, where I know that the next line of therapy is likely to induce a much inferior progression-free survival than the CAR T, and then I would consider that in second line. And there's a question.
When you talk about secondary heme malignancies, you're talking about T cell cancers?
Yeah, that's an excellent question. So that is one of the concerns or potential concerns. But actually, in this case, we have these in the studies. These have not been seen. These are actually more like myelodysplastic syndrome and AML. So not T cell cancers. There was one T cell lymphoma, but it did not. When they kind of looked, it didn't have the insertion, the CAR T insertion. So it's not the ones that the FDA is worried about, where you would get sort of insertion of the CAR T in a different cell and then induce a cancer from that standpoint. These appear to be more from like the treatment related type of disorders that we're used to seeing after chemo.
And indirectly, do you see more with cilta-cel versus ide-cel?
So again, it's always hard to say, but if you look at the studies, the percentages reported in the studies seem to be higher with cilta-cel. But they have been reported with ide-cel as well, just not to the same degree. All right. So we'll move on to, we also saw sort of further data on earlier use of CAR Ts. So this was CARTITUDE-2 cohort B, and this was presented at ASH this year. And basically, patients here had to have one prior line of therapy and progressed after less than 12 months after a transplant or start of anti-myeloma therapy. So these patients would be considered functionally high risk. The expectation right after initial treatment and after transplant is that you would be in some form of response for several years. So progressing after 1 year, that already puts you in a high risk category. And so the primary endpoint was MRD negativity. So these patients all got CAR T as their next line of therapy. And so you can see the overall response rate is 100% with complete response rate of almost 90%. And the MRD result, which was their primary endpoint, was 93%. And the sustained MRD, meaning a year sustained. So you get MRD negativity and then you repeat it a year later. That's what sustained MRD usually means. And 61% of patients did that. And so you see the PFS curve here. So that actually looks quite good, right? If you think about it, all these patients progressed within a year of their initial therapy. So we don't expect the second line therapy to be longer. And in this case, it looks like it might be. So the same thing with KarMMa-2 cohort 2B, exact same population, except they chose 18 months instead of 12 months from frontline therapy. And these were all patients who have had transplant. So they separated the population, so they have two different cohorts. So this is just a cohort with transplant. And so again, functionally high-risk patients, 31 patients, so a bigger number. Great response, 100%, CR rate of 71%. And as you can see, the PFS, I can barely read it from here, but it looks quite good. Again, showing that these patients have a better PFS than what they had before their initial therapy. So sort of a proof of principle. And so then the question also comes up, these two studies, again, with KarMMa-2 and CARTITUDE-2, different cohorts, looking at patients that don't have the optimal response. So we expect patients after induction, after transplant, to be in complete response, to have the best outcomes. And so patients who did not achieve that were treated with the CAR T as consolidation after their transplant. And that's what these two studies are showing. And as you can see, the KarMMa-2 cohort 2C study had 32 patients and overall response rate of 87, CR rate of 77%, and a 36-month PFS of 77%, so quite impressive. And CARTITUDE-2 cohort D, smaller number, 17 patients, less follow-up thus far, but I mean, these look incredible, right? So 94% response rate, CR rate of 82%, and 18-month PFS of 94%. So So these are looking quite impressive. And so because of that, there are now 2 studies ongoing that are going to be the BMT-CTN study is a phase 2 study of the same population with ide-cel, but now there's a KarMMa-9 study, which is a phase 3 study, basically taking these patients who are not in CR after transplant and randomizing them to receive CAR T followed by Len maintenance versus Len maintenance, which has been the standard of care. So it'll be very interesting to see if the CAR T can significantly sort of change the outcome for these patients. And then going forward even further is moving the CAR T to truly to frontline. So CAR T 5 is looking at patients who do not intend to go to transplant. They get induction with VRD for 6 cycles, and then they're randomized to either 2 cycles of VRD consolidation, which was the standard. Perhaps you might think differently after you see Dr. Martin's presentation, followed by cilta-cel versus consolidating with VRD consolidation times 2 cycles, followed by RD maintenance till progression. I guess I should say the standard is actually the bottom arm. And so this would be a very intriguing study because it will test the possibility that we could use cilta-cel as a way to basically do away with maintenance, which would be nice, right? So these patients get cilta-cel and no maintenance. So that's sort of kind of the head-to-head comparison there. And then CARTITUDE-6 is actually in patients who are intended to go to transplant. They basically are randomized right at the beginning, and so you get the quadruplet of dara, bortezomib, lenalidomide, dexamethasone for 6 cycles, followed by cilta-cel, and then len maintenance for 2 years, versus the quadruplet for 4 cycles, transplant, 2 cycles consolidation of the quadruplet, followed by len maintenance for 2 years. So in this case, cilta-cel is going after replacing transplant itself. So pretty intriguing studies. Both of these are already ongoing and accruing very well. So we should have results in the next few years. So, so basically my take from all this is it looks like we definitely are moving very quickly. We know we have the indication now, even after at second line with cilta-cel, for example. So all of these are small cohorts, but they're just a proof of principle to show a couple things that people were concerned about was, can you give CAR T safely when the T cells are more active? Will you see more toxicity? And so far, we didn't really talk about toxicity, but toxicity actually seems less when you move it earlier. And specifically, if you do these as consolidations. So that was one of the concerns. What if you kind of get a patient into a CR, will they be able to expand their CAR Ts? And all of these studies are showing that the CAR Ts expand just as well and perhaps with less toxicity. So I think in my opinion, this is the best way to use CAR Ts, is more as a consolidation after you have the patient under control. And so I think these data are intriguing and really look forward to these phase 3 trial.
So just out of curiosity, if these frontline trials are positive, which certainly seems very possible, if not likely, is there a plan, is there enough CAR T around to actually be able to treat everybody?
Yeah, that's an excellent question. So I think if you talk to the manufacturers, they'll say yes, there is, but that still remains an issue. It has improved significantly. So in the early days when the CAR Ts were first approved, we would be waiting up to 6 months before we could get a spot for a patient. But that actually has changed. So at least in my, and again, this is early, so I have to go with my own personal experience now. But basically right now, if I have a patient, it's really sort of my group's ability to get me a date for pheresis that is the holdup in terms of getting a CAR T product or approved. That seems to have gone away, but we'll see, right? So if people do start, we'll know that now, because as we go and people are getting now second line, third line, that should significantly increase the numbers as well. And so we'll see if there is a snag, because you're right, that is a possibility. But the truth is, most patients, or a lot of patients, are not necessarily going to be candidates for CAR T, right? So the more frail patients, even if they're not going through transplant, these are going to be fit patients. They have to meet the criteria to get a CAR T. So those patients are still not going to be going through transplant. And remember, myeloma has a median age of 69, so that's not a small number necessarily that you would not necessarily consider a CAR T for. But there's similar trials going on with the bispecifics. So it'll be interesting to see which one actually makes the most splash in the front line.
I never thought about this, but roughly what fraction of patients in the United States are transplant eligible or, go for transplant?
Um, so those are two different two different numbers. So transplant eligible actually should be high. If you were in Europe, the age has always been 65. So if you were 65, then you were not considered transplant eligible. In the U.S., we never had an age. It's always been about comorbidities and frailty. And so technically, the numbers for transplant itself should be well over 50%. But if you look at the actual number of patients that get transplanted, it is less than 20%. So
That
a
makes
significant
sense.
disparity there in terms of who actually gets transplanted, who doesn't.
Right.
So with that, I wanted to bring up sort of kind of new CAR Ts. So we've been talking about the two approved products, but this is actually a product that is moving very quickly. It's called the needle-capsid autoleucel, or anito-cel, formerly called CAR T DDBCMA. And the DDBCMA is basically what makes this different. So this does not use a single chain variable fragment like the other CAR Ts. This is a small D-domain construct that actually you can see the size difference here. It's the one in purple versus the SCFEs for the other. The first one would be ide-cel, and the second one is cilta-cel. So much smaller binding site, and presumably that actually keeps it it decreases tonic signaling, so you don't activate each other. You don't, sometimes when you have the CAR T sitting sort of waiting to be given, sometimes they'll interact with each other and activate before you actually give it to the patient. And so the small D domain presumably prevents this from doing so. And they have much more, or they say that much more a better transduction efficiency. So anyway, so they tested 38 patients, two dose levels, 100 and 300. They stuck with the 100 just because they saw much more CRS at the 300, but both were very active. And you can see overall response rate of 100%. What makes this intriguing is the percentage of patients that had extramedullary disease. So 34% of patients had EMD, and those are patients that this was true EMD. So this is disease that is outside of the bone marrow, not contiguous with bones. So, subcutaneous or an actual organ. And so those patients usually do very poorly, even with with CAR T therapy. And so you can see here that those patients responded very, very well to this CAR T with a response rate of 100% as well. And then if you look at the PFS for all patients, it's has not been reached, and it's 56% at 24 months, and it's basically the same for the EMD patients, which is completely different than what we normally see with CAR Ts. Normally, the EMD patients drop very quickly. So we get the responses, but then they relapse much faster. So this is looking very intriguing from that standpoint. And we're not seeing any of the delayed neurotoxicity that was seen with cilta-cel, although again, with cilta-cel, it's becoming a little bit less as we move it earlier, we hope. Or at least that's what the data seems to look like. But nonetheless, it's still a scary toxicity. So this one has not reported that. And so they actually are starting pivotal trials, both to hopefully get indication for the single agent, but then they're also looking at they're starting a phase 3 randomized against standard of care as well, just like we saw with Karma 3 and CAR-T 4. So this is potentially could be the next product approved. And since you mentioned about the access, I think having more products is a good thing, because obviously one may not be able to keep up. So I think especially with CAR Ts, I think because of that potential for manufacturing delays and manpower, I think having several products makes a lot of sense. And then the last thing I wanted to say about CAR Ts is that now we have a CAR T that is not going against BCMA. So we have a CAR T going against this GPRC5D, which you've heard about with the bispecifics. And so this is CC95266. This is our phase 1 trial of this CAR T. It was given at 25 up to 450, and 150 was found to be the recommended phase 2 dose. And so what was presented this year with this CAR T product was that they had a cohort that allowed patients 1 to 3 prior lines of therapy. And so that's the one that was presented here at EHA actually just a few weeks ago. And so again, these patients had an excellent response to the CAR T, 96%, 42% complete response rates, and we'll see how durable it is, but it's looking quite good. I will alert that, in terms of CRS, 81%, mostly grade 1, 2, very similar to the BCMA CAR Ts. ICANS type neurotoxicity, again, very low, just like with the other CAR Ts. But what's interesting is that they did see this neurotoxicity that was seen a little more in the other cohorts, but even seen in this cohort as well, of more of a cerebellar type of toxicity that can result. And so GPRC5D may be expressed in a different part of the brain than BCMA, which may be mediating some of these toxicities. But so far, this toxicity seems very reversible, and it seems to be more as you increase the dose. And so and that was part of the reason why the dose, even though it went up to 450, we decided to just kind of stick at 150. I'm sorry, I say we because I'm in this trial as well. But before I answer your question, I will point out, just keep in mind these numbers for the on-target, off-target adverse events, which we'll talk about when we talk about the bispecific. You're definitely seeing these toxicities, but we're seeing much less in terms of percentage, and also the degree is much less, and also the duration. Again, just kind of keep this in mind. We're talking 10 to 20% versus the numbers you'll see with the bispecific. Yes, sir.
Just curious, the Parkinson's-like neurotoxicity with cilta-cel, is that considered a non-ICANS type?
Yes. So ICANS, which is immune effector cell-associated neurotoxicity syndrome, is specifically sort of kind of it's usually seen early, and it tends to be around the time of CRS. Although you don't have to have CRS with it to be ICANS, and it's a much different syndrome. We still don't know the exact reason why it happens, but when it does, it tends to be a more kind of global effect, sort of initially with some confusion, but it can actually eventually lead to a whole brain edema and seizures, etc. But it tends to be earlier. This other neurotoxicity, and we're struggling with what to call it, but at least for now, it's sort of this other neurotoxicity that tends to happen later. So with cilta-cel, there were 12 patients that had toxicity later, and some of them were Parkinsonian-like, and some of them were sort of cranial nerve type disorders, and that was seen on average at day 27, whereas the ICANS was seen on average at day 8. So again, it's sort of kind of later. Usually by day 30, we're sending patients back to their doctors, right? So it's a late toxicity. This particular toxicity with the GPRC5D products seems to be, and it's been seen now with 2 products. It's a little bit less specific in terms of when it can happen. It can start early and then continue, but can also start later. So, but yeah, these will be considered different than ICANS, which is why here they're using the term non-ICANS type neurotoxicity. So my conclusions with this new CAR T is the first. There's 3 now that have been reported, but really 2 that are being potentially kind of moved forward. GPRC5D CAR Ts, but none, of course, are FDA approved at this point. We're seeing efficacy, and then one of the things that I didn't mention here, because in this cohort we didn't have it, but in the study, the same study with all the cohorts, about half of the patients that had prior BCMA therapies, including BCMA CAR Ts, and we saw very good responses. So this may be a nice sort of kind of type therapy that can be sequenced with the BCMA therapies. The cerebellar neurotoxicity still needs to be defined. That's not a nice toxicity, obviously, and hopefully it's true that it's dose related, and as we're sort of able to move the dose down, now that we know this and we're seeing less, hopefully that will become less of an issue. And then I would argue that the on-target off-tumor toxicity appears less than with the bispecifics, and so perhaps this target may be a better target in a CAR T as opposed to a bispecific. But again, more to come on those toxicities. So with that, I'm going to move over to the bispecifics. And obviously, the first bispecific that was approved was teclistamab, and this was based on the Majestic 1 trial. We had an update on this trial, which is why I'm showing you these results again. But just a reminder that this was a heavily pretreated population that got the bispecific antibody, BCMA directed, of course, IV, and then eventually sub-Q, and then the recommended phase 2 dose, 1,500 micrograms per kilogram sub-Q Q week. And so we saw at ASCO this year sort of longer-term follow-up, now out to 30.4 months, and basically everything is standing and is looking quite good. So the overall response rate still is about 63%, 46% complete response rates are better. But what we're seeing over here on the right is the curves, the survival curves, duration of response and progression-free survival. So duration of response on the top, the overall, the yellow ones show the overall, and as you can see, the median is 24 months, and overall PFS of about 11.4 months. But then the red curve actually shows the patients who achieved complete response, and you can see the duration of response has not been reached at 30.4 months, which is quite impressive, and the PFS equally has not been reached, and is 61% at 30 months. So going to show that these responses can be quite durable, which is nice to see. So basically, again, these were patients heavily pretreated. Even though the median PFS is about a year, 11 months or so, the patients who do get a response seem to be staying in remission quite a long time, and so that's very encouraging. And no new toxicity signals. As a matter of fact, actually, we are seeing potentially even less infection. And so what we're learning is that now, with time, there's some data showing that if you decrease the frequency of the bispecifics, once you reach a certain response, that you tend to mitigate some of the immunosuppression and decrease the infection risk. And that actually has been shown with this as well. And so they got that FDA approval that after you get a complete remission, that you're able to then decrease the dosing to every other week instead of weekly. Question.
Yeah, I was just flashing on the fact, I think it was your patient that was one of the most memorable videos I've done since the pandemic. I believe it was your patient who I did a video of a year and a half ago, who was on teclistamab the week it was approved. The man,
Yes.
do you remember him?
Yeah.
I use him as a perfect example of being, he'd been on it for a year and a half the day it was approved.
Right.
I use him as
Right,
as the example. How's he doing?
And he's still doing well, actually. And I think
He's still on
one of the things
teclistamab?
he's still on teclistamab.
It's a year. I mean, it's a year and a half later, right?
Yeah.
It's
So
a year,
no, I mean,
year and a half since it's approved. Yeah.
some of these patients do really well. Now, what's interesting is that there's patients that come off for toxicity. And we've seen this with all of them, where, for example, you get an infection or for whatever reason, the patient has to be held. And some patients just don't go back. And I've had patients who achieve a remission after even just a couple cycles, and stay in remission for like a year before we have to restart. And then when you restart, they go back in remission. So we may not have to give these drugs continuously, and we may be able to actually give people breaks, which ideally would be the ideal, right? That if we knew that if we get to a certain depth of remission, that we can actually stop and give people a break, and decrease that potential infectious burden, I think that will significantly improve these drugs. But at least for now, they're all indicated for continuous infusions.
Yeah, myeloma can become the new prostate cancer with intermittent therapy.
That's right. I don't know if I like that comparison, but yes, at least in terms of I think in terms of survival, though, you're right. Right, we're reaching those levels of these sort of more indolent
Well, I'm
therapy
talking about intermittent.
diseases that. No, I know. But I mean, I'm saying the comparison is actually not bad because it's becoming almost like a prostate cancer where people can live many, many, many years with it, even in the stage 4 setting, right? So.
Yeah, you see that model throughout oncology with MRD and all that, but they've had PSA for a long time, so they have a big jump on everybody.
That is true. All right. So But similarly, we have several BCMA CD3 bispecifics in the market. The second one that was approved, or the two are approved. The second one is from the Magnetism MM3 study. This is elranatamab. And so again, heavily pretreated population, 187 patients enrolled. Here's the response rate, very deep response rates as well. But we actually had at EHA this year, again, just a few weeks ago, an update on this, also showing us sort of they had not reported their median PFS. It had not been reached, but now it has been reached. So if you look again at these curves, the here is backwards. So the patients in red are actually all the patients versus the ones in yellow that are patients CR or better. So you see the duration of response for all the patients has not been reached at 24 months, but is 66.9% at 24 months. And the PFS for the entire group now has been reached in 17.2 months. So actually quite impressive PFS. And then if you see the patients in yellow there, the patients that achieve CR, that 24-month PFS is 90%. So those patients are all staying in that remission. And you saw it was about 40% of the patients. So it's not a small group. And the overall survival looks fantastic, right, for these patients who often were sort of in their last line of therapy or potentially last line of therapy. So almost 25 months. So again, similar to what we saw with teclistamab, elranatamab is looking fantastic, and it's also approved in patients with 4 or more prior lines of therapy, prior IMiD, PI, and anti-CD38 antibody, which I forgot to tell you is also the same indication for teclistamab. And we now have a median PFS, looks fantastic at 17.2 months and no new toxicity signals. And this is also a bispecific that allows for you to go from the weekly dosing to every other week after 6 cycles of therapy, as long as you have a PR or better. So again, and you'll see this a lot, that is going to be the trend, and again, hopefully getting to the point where we can actually stop it. I did want to, at EHA, we saw updates on a couple of 2 BCMA CD3 bispecifics that are sort of probably the next 2 to potentially be approved. This is linvoseltamab, and this is the linker MM1 study. And what's interesting with this one is that the step up's a little bit different. So with bispecifics, you don't give the full dose right away. You actually start with the low dose and then you step it up slowly before you give the full dose. And so the step ups can be 2, 3, even up to 4 steps before you give the full dose. And so after each step up dose, you need to sort of observe the patient for 24 to 48 hours, depending on the bispecific, and sometimes even in the hospital. So that is important. So in this case, they just have 2 steps requiring only 24-hour hospitalization after each of the steps, and they're a week apart. Most of the others are 3 days. So as you start comparing these, it's like if they're all very similar, there will be sort of the easiness, right, of easiness of giving some of these may actually help potentially push one over the other. And the other thing that's interesting with this one is it starts once a week, but you see then it drops to every 2 weeks. And then if the patient's in VGPR or so after 6 months, it goes to every 4 weeks. And so actually this is actually even less frequent than what we've seen with some of the others. So again, overall response was 71%. The others were similar. All of these are giving very similar response rates, but half the patients had CR or better, and with a median follow-up of 14.3 months at this point. So looking quite impressive. And here are their progression-free survival and duration of response curves. And here, same thing. So the purple is all patients, and then the green is CR or better. And as you can see, the median PFS for all the patients has not been reached, but it's looking quite good. So it's definitely going beyond a year. So so similar in my mind, all 3 of these are looking very similar, all quite good. In terms of toxicity, again, the CRS seems to be a little bit less, but again, it's always hard to compare between the studies. But is it because they're giving it less frequent that we're seeing less CRS? It's unlikely, since the CRS occurs just in the first step of the first dose. So, but anyways, 54% or less than 50%, which is, most of the others are at 60, 70%. So it's unclear whether that's true or not, but definitely at least going in the right direction. Infections still continue to be the main issue. I didn't really go into this with the others since those were just more sort of longer term presentations, but you can see that, infections occurred in 74% of the patients, and about half of them had grade 3 or 4 infections. So again, these are nothing to sort of be dismissive about. These are important complications. So they're expecting FDA review this summer, and obviously everyone's hoping, and they're hoping that they will be approved, and it'll be the third BCMA CD3 bispecific. It's an IV. The other ones are sub-Q. Whether that makes a difference is unclear. But as I said before, the 2 one-day hospitalizations versus 3 to 6 days for the other products may be a benefit, but toxicity is similar. So we'll have to see how we all end up making these decisions about which one to choose. And then the final BCMA CD3 bispecific I want to talk about is ABBV383. They had an update at EHA as well, and this is actually a little bit interesting. It's a little bit different in that it has it's designed specifically to sort of have a lower affinity to CD3 and higher affinity to BCMA. And presumably the idea there was that you would still retain the response, but because of the lower affinity CD3, that you potentially may be able to mitigate the CRS and ICANS, or at least that was what their thinking was. And so again, they're given, they've done the dose escalation. This is their phase 1, and this particular report was about their 3 highest doses: the 40, 60, 40 or 60 at every 3 weeks, and then the 60 every 4 weeks. So a much less frequent dosing. And this is actually the dose that they chose that they think they're going to move forward with, is the 60 every 4 weeks, which is nice actually compared to weekly, right? So again, in terms of toxicity, some cytopenias, which you see with all of them, but look at the CRS. Initially, with most of them, 71%. So what we saw with the others, but when you actually look at the Q4 week dosing, which even though it's the highest dosing, only 43% and 0 grade 3/4. So we'll see. So I don't know if it's because of the less frequent dosing or because of the actual low affinity to CD3. But again, the dosing interval shouldn't matter, because once we get beyond the dose escalation, we don't see CRS after that. So it may be true that their CD3 low affinity may make a difference. Overall response rate similar to the others, 65%. You can see the PFS curves here. They're still pretty early, so they have not reached their median PFS either. So they're actually a little bit further behind. But what I like about this is that it allows for Q4 week dosing, maybe less CRS. We have less infections, is what we saw with the others. It seems to indicate that the less frequent dosing may help. So they're actually they're in the process of enrolling to the registrational phase 3 trial called the Cervino trial. And that is the dose, 60 milligrams Q4 weeks. All right, so I'm going to move now to the one and only GPRC5D CD3 bispecific that is approved in myeloma. It's called talquetamab. And so here I'm going to discuss the GPRC5D a little more than I did with the CAR-T. So GPRC5D is also very specific to myeloma cells. And it's even actually, the nice thing about it is that it's expressed a lot more in malignant cells than in normal plasma cells, which is not the case for BCMA. BCMA is expressed just as much in both normal or malignant plasma cells. And so we all think that perhaps because of that, you're seeing less infections with the GPRC5D products. But the problem is that there is a low level of expression of GPRC5D in the surface of the tongue and in the highly keratinized tissues. And so because of that, we are seeing these off-tumor, on-target effects, including taste disturbances, dysgeusia, dry mouth, rashes, nail dysmorphia, brittle nails, etc. And those are actually not unexpected, unfortunately. So again, so this was Monumental 1, and we had an update at EHA on it, which is why I'm showing it to you. But remember that the 2 doses are approved, zero 0.4 milligrams per kilogram sub-Q Q week, or 0.8 milligrams per kilogram sub-Q Q 2 weeks. And because this is a GPRC5D, this study was done and allowed prior T-cell redirecting therapies. Most of them, of course, were BCMA. And you can see that 78 of the patients actually had prior BCMA therapies, but they're pulled off to a different group over here. But you see the overall response rates are quite impressive, about 70% in both arms. And then even the prior TCRs had an overall response rate of about 68%. Very deep responses, mostly VGPR and CR. And the duration of response you can see here is it seems to favor the Q2 week dosing of the 0.8 at 17.5 months. But it wasn't reported with the prior TCR. But if you look at the PFS of the prior TCR it seems to be a little bit inferior to what we saw with the Q2 week dosing of 11 months or so. So both doses are approved by the FDA, but I suspect most people are using the Q2 week dosing. Again, the numbers look a little bit better, and I know these are small numbers, so we can't really compare. But also the less frequent dosing, most patients prefer that versus having to go every single week. In terms of the adverse effects, again, I wanted to concentrate here. Well, actually, before I get into that, you can see the CRS rates in the 70%. So similar to what we saw with the BCMA CD3 bispecific, most of them grade 1, 2. But then you see this in the box, you see these off tumor on target effects. And so you see the percentages there, both with the Q week and Q2 weeks. We're looking at skin-related AEs of 60%, nail-related changes in about half the patients, dysgeusia, which is sort of the taste disturbances, half the patients, rash in about 40% of the patients, and weight loss. So these patients, dry mouth, they can't taste, they actually dropped their weight. And 40% of the patients had clinically significant weight loss. And the problem with this is that there's no grade 3-4 dysgeusia. There's no grade 3-4 rash or nail dysmorphia. So all we can report is up to grade 2. So the grade here doesn't really tell you sort of kind of the true quality of life of these patients. And so that is a problem with our current AE grading system. But if you recall with the CAR T, we were looking more of like 10 to 20% of patients. And what's really interesting is with the bispecific, these symptoms don't go away until you start either decreasing the frequency and really until you stop the drug altogether. And then those symptoms go away. With the CAR T, the patients who do get these symptoms seem to get them for about a month to 2 months, and then it just goes away. And so presumably, that has to do with the expansion of the CAR T, and then you drop the T cells, and so you're no longer redirecting T cells, whereas here you're continuously redirecting T cells. But that's part of the reason why I made that comment earlier about perhaps GPRC5D may be a better CAR T target. But nonetheless, this still works really well, and it works really well in patients who failed BCMA. So again, talquetamab is the first GPRC5D CD3 bispecific approved for myeloma. Same indication as the BCMA bispecifics, adults with 4 more lines of therapy, including an IMiD, a PI, and an anti-CD38 antibody. And then obviously we still need longer follow-up, but the longer follow-up, I guess, data that's shown shows that the Q2 week dosing appears more durable and great responses even after BCMA therapies, which would obviously help us in terms of sequencing. And then toxicities, though, I didn't really go into the infections very much, but definitely they seem to be less, and we see less grade 3-4s than we with the BCMAs. And so part of that may be because even after, while you're on therapy, we start seeing normal plasma cell recovery. And so some of these patients actually do regain some of their humoral immunity even while they're on therapy and still in response, which you don't see with the BCMA products. And so that may be part of the reason why we're translating or seeing potentially less infections. But these off-tumor on-target effects can be very difficult for the patient. So in my experience, you really need to counsel patients, and if they're expecting it, they tend to tolerate it better. If it hits them, if they're blindsided by it, a lot of patients want to come off very quickly. But I've been successful in keeping my patients on and not had anybody come off because of these side effects. But definitely they can be difficult for some patients. And then finally, I'm going to end with Lazarus, I guess we'll call it. And so this is Dream 7, which is a study of this drug called belantamab mafodotin, which I'll just remind everybody, it's an BCMA-directed antibody drug conjugate that was FDA approved in the same, sort of in the relapse refractory setting, just like the bispecifics. And with a response rate of about uh, sort of kind of in the 30 to 40%, and a PFS of about 4 months. And it had some ocular toxicity as the main side effect, specifically keratitis that require ophthalmology exams before each dose. They did their confirmatory study, which basically randomized patients to belantamab mafodotin against pomalidomide dexamethasone, and that was a negative study. So because of that negative study, the drug was actually removed by the maker of the drug from our market. And so now, fast forward to these results of the Dream 7 study, which is basically a phase 3 study randomizing patients to either belantamab mafodotin in combination with bortezomib dexamethasone versus daratumumab bortezomib dexamethasone. So a very well-known standard of care. And so the belantamab here is given at a lower dose of 2.5 milligrams per kilogram every 3 weeks, and was allowed to actually decrease significantly up in the sort of after the initial sort of kind of therapy. Patients could get it as infrequently as every 3 months. And so this is what will wow you here is the PFS. You can see the belantamab arm is on top in red, and the dara bortezomib dex is in yellow. So the median PFS of 13.4 months for dara bortezomib dex is what we saw in the initial studies for with that combination. But the median PFS for belantamab with bortezomib dex is 36.6 months, so unheard of, right? So those are numbers we're seeing with dara carfilzomib dex and potentially with cilta-cel. So quite impressive numbers that surely most likely will get this back approved in combination. Same with overall survival. You see, we're already seeing a difference at 18 months. And so similarly, the Dream 8 study was also reported. And this was belantamab in combination with pomalidomide dexamethasone versus bortezomib pomalidomide dexamethasone, which again is a standard triplet PVD, randomized, and both of these studies were done in patients one prior line, at least one prior line of therapy. And so again, this is a little bit earlier, but you see the separation of the curves with the belantamab on top in red at 12 months, 71% PFS versus 51%, and survival advantage. So again, looking quite impressive. So I think these results are going to get the drug back on our market, and so we'll have a. This is the first time we've had a triplet versus triplet where the daratumumab triplet was defeated. So this is actually another impressive thing, right? So they actually chose a pretty good control arm, and so I think this data looks fantastic. The ocular toxicity remains an issue. But definitely, I didn't show you the toxicity here, but appears improved, especially with the lower dose and the less frequent dosing. And we knew that from the earlier studies. And so we're starting to move before, we'll see what the FDA decides to do with this. But before, the company had been very conservative, and the studies were done and required that basically you get an ophtho exam before every single dose. And if you had, even if the patient was asymptomatic, but if grade 2 keratitis was seen by the ophthalmologist, we had to hold the dose. And now we're going to a more sort of symptom-based assessment, so that if the patient is asymptomatic, that they shouldn't even require that ophthalmologic exam and can continue their dosing. So, so hopefully that will make it less cumbersome. We'll see if the FDA agrees. But if it's approved as early as second line, it will make the sequencing of the BCMA drugs very tricky, right? So now we're going to potentially have belantamab, which is an BCMA ADC in combination, a second line, as well as cilta-cel in second line. And so we'll have to kind of decide which one we do first. Part of the problem is, and I didn't show you this data, is when we talk about sequencing, the CAR Ts don't work very well after you give a BCMA drug. So in patients, there was a small 20 patients in the cohort, CARTITUDE-2 cohort C, I believe, where they actually looked at patients after getting belantamab or after getting a BCMA bispecific, and we're given cilta-cel, and the response rates compared to CARTITUDE-1 data went down from 98% in CARTITUDE-1 to about 60%, and then the PFS went from almost 36 months to 9 months, and actually after a bispecific, it was only 5 months. So giving the CAR T right after patients progress on one of these drugs is not a good idea. Um, so, so it's going to be tricky. So it's going to be interesting to see how we do this. Now, obviously, if a patient received this in second line and then they have several lines in between, and it's been a year or more since they received, that may be a different story. But the sequencing, I think, will be challenging.
Yes, just a couple of follow-up questions. Just first, that last point that you were making, I think that question's been out there for a while. Even in CD19 bispecific and lymphoma, does prior therapy affect it? And until today, when you just made that comment, I hadn't heard anybody say that. Is this like the first, or has been out there for a while?
Well, no, we're learning a lot more. So, but it's definitely been out there. So there's the problem is a lot of these therapies are coming out together, right? So a lot of the data that we have is in really small numbers, and so that's one of the problems. The other problem is a lot of the data that we have is from real world settings, and as you know, that's always has potential problems in terms of data interpretation. But the real world is actually the first time that we started seeing these patients that had, were getting their CAR
Hmm.
T and they had been in a clinical trial or had prior belantamab, because belantamab, remember, was actually the first BCMA approved, directed drug that was approved by the FDA. So some patients had received ADCs before they got CAR Ts. And so we started seeing that signal that, and the idea, I think, is twofold. I think one is, if you're coming off an ADC, are you progressing because you've lost BCMA? That's a possibility, right? You're truly refractory to BCMA. And so maybe going after BCMA doesn't make any sense. The other is if you're giving a bispecific and you're progressing on that bispecific, those T cells have been redirected continuously. So one of the potentials is that now you have very fatigued T cells and you're making CAR Ts out of them and it won't work. But the other is there was this very nice paper that came out last year from a Canadian group that actually showed that patients on BCMA CD3 bispecifics developed point mutations at BCMA that prevented binding of subsequent
Hmm.
bispecifics. And so theoretically, now you're adding mutations to the BCMA, you have fatigued T cells, you can kind of you can start seeing the sort of the writing on the wall that these autologous CAR Ts are just not going to do so well. So most of us, whereas there's actually some data that if you had a CAR T, one of the nice things about CAR Ts, you're off therapy for potentially even up to 3 years, right? And so those patients seem to be resensitized to therapies. And so when you look at the data of prior CAR T, especially if it's been at least 6 months from the CAR T, and then you give a different BCMA drug, that you actually are seeing good responses. And we saw that with the talquetamab. We've seen that with the GPRC5D CAR T. So that all things being equal, most of us, if you ask most of us, we probably would tell you that if the patient's eligible for all three types of drugs, that a CAR T should be done first. If that patient's going to be eligible for a CAR T. And then if the patient's not eligible for a CAR T, then you kind of go with the others. Or if the patient just CAR T is just, like you said, you're just a wait list, or you can't manufacture, or the disease is moving too quickly that you can't move to a CAR T. That's when you start thinking of the others. But yeah, no, I think it will be very intriguing because obviously in the community docs are going to give probably what's easiest, right? So my guess is we'll have a lot of patients sent to us who already had an ADC or a bispecific. Now, right now, only the ADC would be potentially approved early, so that's the one that's, I think, going to be more challenging. The bispecifics are still approved pretty far back, but they'll be moved, just like we do everything else in myeloma.
So one final question. I mean, it's certainly not a surprise when you see an ADC that has a big effect, and Fortimab's first line therapy in bladder cancer, TDXD. There's lots of ADCs out there that are really impressive. But, clearly these Dream 7 and 8, I mean, I personally was shocked. I'm sure everybody else was very, very surprised. And
Yeah,
I
no,
guess
that's
the
true.
question I have, when belantamab was pulled off the marketplace, it was hard at that time for me, like talking to you all, to figure out how effective it was. Incidentally, when I did that thing where I interviewed a bunch of patients, I think it was Natalie's patient, I interviewed a woman who was on belantamab for 4 years. And the thing I
Yeah.
was, now that we see the effect on this drug, was that a surprise? I mean, you all were using the drug for a while, yet it seemed like this came as a surprise.
Well, I think I'll tell you what's surprising. I agree with you that one of the intriguing things about belantamab, and the reason why we were all we, we we were disappointed that it was taken off the market, is that A is an easy drug, and most patients feel fine on it. But also in those patients that do achieve deep responses, is very durable. I mean, we all have those kind of patients like Natalie that basically, like, they were on it for, like, 2.5 years or something, and or they got, a remission. They came out because of keratitis, and they maintained that remission. So this is not just a simple ADC. I think, ADCs in the past in myeloma have not worked very well, and they were truly just basically delivering chemo. But we don't use that much chemo in myeloma, right? But this is also, I think, an immune therapy, and so I think it's the combination of the two that are making this a little bit different. But I think what we were surprised by was the response rates with this, right? Because, I mean, they were like so much higher, because bortezomib dex alone should not be giving you these kind of response rates. So definitely there's a synergism with the PIs that I think was impressive. But then also to then have this PFS of 3 years, when we know that even the dara bortezomib dex is only a year, is the impressive thing. Because even in, the PFS was only 4 months for the single agent of belantamab. So how do we go from 4 months, and then dara, a bortezomib dex that maybe is 6 or 7 months, you put them together, and now we're talking 3 years. So I think that's what was surprising, that the degree that it improved the benefit.